Okay, let's go. So I have the dubious honor of presenting the last TUT for the year. I hope it's a good one. So today is the second lecture on cerebral palsy. If you can't hear me or you can't see my screen, just raise a hand or something, but I think everything should be fine. And in today's lecture, we'll be speaking most about non-ambulant CP, as well as the upper limb in cerebral palsy. Let me just get myself organized here. Okay, so the treatment priorities in patients with non-ambulant CP is very different to those with ambulant CP. So function is not really a huge priority, especially in the GMFCS5 patients. It's mostly prevention of pain, facilitating seating and hygiene and care. And this, amongst other things, includes a chewable foot. So also just a disclaimer, this is not going to be a very interactive lecture because it's not a subject that's really amenable to, oh, what do you see here? Because it's going to be predominantly hip dislocations. So the most common complications or the most common problems that we encounter in the non-ambulant cerebral palsy patients is first and foremost hip subluxation and dislocation. And this is probably the vast majority of surgery that I perform for these patients is for the treatment and prevention of this. Scoliosis is also very common, knee flexion deformities, foot deformities, and then upper limb deformities. So it's basically the whole body, come to think of it. So we're going to start and focus on hip dysplasia for a while because it is such a pertinent topic in this population. So the level of involvement is directly related to the level of involvement in the severity of the CP is directly related to the incidence of hip dysplasia. So it is virtually unheard of in your ambulant CPs, mostly, or like as low as 2% of them will have hip problems. And this is predominantly in the type 4 hemiplegics, which are the most severe form of hemiplegia that have hip involvement as well. But it can be as high as 90% in certain reports in patients who are GMFCS level 5. So the pathophysiology is poorly understood. I think there's a variety of factors at play. But we know that these children are born with normal hips and their problems develop over time. So adductor and pseudospasticity play a role because they overpower the abductors and extensors, placing the hip in an unfavorable position, which predisposes to proximal migration. And then another factor is the persistence of fetal anatomy. So babies are born with increased femoral anteversion of approximately 40 degrees, as well as femoral neck valgus. And this all normalizes as these children start to walk. So the CP patients, the non-ambulant ones, never walk. Therefore, those normal forces that lead to remodeling of the proximal femur never occur. So they've got this persistent anteverted valgus femoral necks. So basically, due to this imbalance between the muscles and the pathoanatomy of the femoral head, it is the head is driven into the posterior superior acetabulum. So there's a difference between the direction of dislocation in cerebral palsy and DDH. DDH patients, that dislocations are typically anterior superior or anterolateral, and it is posterior in the CPs. So this leads to progressive subluxation, acetabular dysplasia, femoral head deformity, arthritis, and the end stage of this process would be a painful, stiff, irreducible dislocation. And this is just 2 examples of such patients. You can see they look very similar in terms of what's happening with the femoral heads. There's complete abnormal shape, loss of cartilage, loss of sphericity, deep craters almost in the head over there and there. And even here, you can see there's a flattening of the medial aspect of the femoral head, and that's where it is being sort of pressed up against the femoral head. And this is what it looks like. So I'm forever taking pictures of these heads because it disgusts me so much, because this is a 100% preventable condition. This should not happen. And as you can see there, the entire cartilage surface is eroded. There's nothing. These are horrible and incredibly painful hips. So one of the major predisposing factors to especially unilateral hip dislocation is the phenomenon of the windswept hips. So my theory, and this is supported by some of my colleagues, but not necessarily by good, robust studies, is that the windswept deformity is driven by the knees. So these children, almost the first thing they develop, a very young age already, is hamstring contractures. If you cannot lie flat on your back with your legs straight and your knees are in obligatory flexion, gravity will make them fall towards one side or the other, as is clearly demonstrated in this kid. He doesn't have extended knees and windswept hips, he has flexed knees. And this then leads to the windswept position, where the one hip is adducted, flexed, and internally rotated, and the other one, the opposite sort of deformity. And there's always that top loop, the adducted, internally rotated, flexed hip, that becomes the dislocated hip in the unilateral cases. There are, of course, exceptions to those patients with bilateral hip dislocations, but this is a very sort of common phenomenon, is the unilateral hips. This also then leads to pelvic obliquity, and we're going to get into that a little bit more in detail when we speak about the interplane between the hip, the pelvis, and the spine. And then subsequently, it's also associated with scoliosis, although there doesn't appear to be any clear relationship between the presence of a dislocated hip and scoliosis, other than that they both occur in severely affected patients. Why is it important? I've said this already, but it becomes incredibly painful. And these children live. So historically, patients with severe cerebral palsy would not survive much further than the early second decade. So in the early teens, they would die. But now, with improved medical care and so on, basically the Red Cross, they all get PEGs if they can't swallow. They're well nourished. They're being kept alive, anti-epileptic medicine, melatonin so that they can sleep, whatnot, PEGs, Nissen's fundoplications. There's no limit to what's being done for these children. And to then allow this hip to sublux and dislocate and become painful is actually just criminal. So we are kind of obliged to treat it now, as these patients do survive. So it leads to pain, seating imbalance, decreased hip abduction, which then leads in turn to poor perineal hygiene or difficulty in maintaining perineal hygiene, and then just general care and dressing these patients. How we quantify hip dysplasia or hip displacement is with Reamer's migration percentage. And the drawing of the lines and the measuring is really, I mean, it does tend to overcomplicate the matter a little bit, and this is the correct way of doing it. But essentially, it is the percentage of the femoral head that is outside of the joint. But this is how you measure it. So you must draw Hilgenreiner's line first, because there's often accompanying pelvic obliquity, as you can see in this X-ray. And you draw Perkins line, and then these lines are actually incorrect. Now that I look at it, especially on the right side, something's wrong. Oh, no, it's fine. So there's Perkins line, sorry. And then the most medial aspect of the metaphysis and the most lateral aspect. And then it's the ratio of how much head there is outside the joint over how much head there is in total. So like I said, essentially the percentage of head that's outside the joint. And then the subtle signs we look for, we teach the fifth years, is Shenton's line. So even in very early subluxation, as you can see in this hip, that has less than 30% migration, Shenton's line is already broken. And that is largely attributed to the severe coxa in most cases. So that's how we quantify displacement. And often the senior registrars that rotate through Red Cross would want to apply Reamer's migration percentage to other conditions such as DDH. It's not wrong, because to a certain degree you're still describing the amount of displacement, but it is typically described and traditionally used for CP, not for other forms of hip subluxation. The acetabular index, however, is quite universally used for pediatric hip dysplasia, and here you can just see the normal values. So by the age of about 3.5, your acetabular index should be less than 25. And then even then it's not really considered normal. So anything more than that is considered too much. And as you can see in this patient with the unilateral marked subluxation, there's very clear acetabular dysplasia as well, with the AI of approximately 45 degrees. So this brings us to the whole prevention of hip dislocation practice, which is termed hip surveillance. So this is proactive identification of hips at risk, hip subluxation or displacement. There are various protocols being followed internationally, especially, of course, in your northern countries, your developed countries. They have a very robust, universal hip surveillance programs for all patients with cerebral palsy. Needless to say, we don't have that here. We do try. But it's basically a combination of clinical and radiological examination depending on the patient's GMFCS level. And here, this graph just indicates the incidence of hip displacement according to the Remus migration percentage in the various GMFCS levels. And you see it's not a big deal in the walkers at all. But as you get to the non-ambulant patients, very high percentage of them will have markedly displaced hips. So this is the hip surveillance protocol that I've implemented at Red Cross, and it is sort of getting traction now with the pediatricians and the neurodevelopmental guys, because they come to my clinics, and I stuck up a little poster in their offices, and I'm getting a lot more early referrals and early recognition of hip dysplasia from them. Unfortunately, I still get a lot of very late referrals from elsewhere. But that's basically what we do. So for the independent walkers, I would say a careful clinical examination is usually adequate, although the protocol does say that you should consider or you should do an X-ray if there's less than 30 degrees abduction. So that's fine. One X-ray and then you're happy. With the GMFCS 3s to 5, they get one X-ray at the age of 2 and then annually until the age of 8. And if it's still normal, then biannually or PRN. But the key here is early identification. There's very few patients who will suddenly develop hip displacement late in life. It usually happens early on during the first decade of life. Late is very unusual. Okay, so those are your hips at risk. If the migration index is more than 25% and there's a disruption in Shenton's line, as we've said. So this is just looking at a little bit of the evidence, and this is from Sweden. They've got a universal hip surveillance program, which is extremely effective. So they've got this protocol here, which is roughly what I'm advocating as well. And they managed to bring down the hip dislocation rate from a very low 8% already to 0. So it works. And the preventative surgery that can be done, and we're going to get to all of that in detail later as well, is your soft tissue releases, hip-guided growth, femoral and pelvic osteotomies. The bottom line is don't let the hip dislocate. You don't just sit and watch them dislocate. Stop it from happening. But what are the options? Who do you operate on and when? And there's unfortunately quite a few options. But I think if you think about it systematically, and that's how I'm going to try and present it to you, there's going to be a fairly clear answer to each hip that presents to you. So on the menu is our non-operative measures, so physiotherapy, Botox, etc. Then your soft tissue releases, and this is like a little package for hip dysplasia, which includes the adductus, longus, partial brevis, and gracilis. You can do proximal or distal, the medial hamstrings, and the psoas at the lesser trochanter. So that's the package. Hip-guided growth, I now routinely include in the soft tissue package, and I'll show you some extras of what that entails. Then as the migration index progresses, a varus rotation osteotomy, some form of acetabuloplasty, I prefer a Daiga. And then as a last resort, when the hip is already out and in a horrible condition, there is salvage procedures where you basically excise the hip joint and then potentially arthroplasty. So the non-surgical management doesn't work, basically. So physiotherapy, Botox, it reduces plasticity, but it doesn't prevent subluxation. And I think this is probably the case for most physiotherapy in term, like for everything, because if you're trying, you cannot compensate for the lack of walking with physio. We walk, I don't know, all of us with our smartwatches, what, 10 to 15,000 steps a day. No amount of physiotherapy is going to mimic that or to reproduce that. And that's what you need for normal muscle length, for normal hip development. And that's just not going to happen. So physio, it helps a bit, I think, but it doesn't actually prevent this from happening. I personally don't do Botox at all for quads. And it's a principle thing. So Quadriplegics have generalized spasticity. Botox is indicated for focal spasticity. It's too global. They have a slightly higher rate of complications with Botox, although it's still negligible. And it's just too much. I mean, you cannot Botox every muscle in the child's body. And in the quadriplegics, generally, their spasticity is so global that for you to have any, what's the word I'm looking for? Any noticeable effect, you'd have to Botox the whole body. So we just don't do that. And here was just another study that looked at this, and it says the hips continue to displace, maybe at a slightly lesser rate, and they do not indicate Botox for the prevention of hip displacement. So in terms of who gets what operation, this is a treatment recommendation from a big children's hospital in the States that I've always sort of used as a reference. However, it is relatively old. It's about from 2011, 2012, and I no longer really agree with it. So if you see what they recommend is that for up to the age of 8, for migration percentage, 30 to 60, only soft tissue releases. So I don't think that's enough. 30 to 60 with the hips that can abduct, nothing, definitely not. And then the rest I agree with. But I think they're way too conservative with their surgical interventions according to this protocol. This was also, yet again, another interesting study. You'll see this guy's name quite often, Kerr Graham. He's like a hotshot in cerebral palsy from the States. So he's done quite a few studies on this. And they looked at what predicts failure for if you only do your soft tissue surgery, which is sort of the traditional thinking for CP. And this is just sort of like what they did for them: adductor longus gracilis, abductor brevis, iliopsoas, and then sometimes abductor neurotomies. We don't do that anymore. Sometimes the registrar will do it by mistake, but it's not really part of the protocol. And this is what they showed. So they had a 68% failure rate if only soft tissue surgery is being done. So it is not enough. And you can see how this, so it does very well for the GMFCS2s, and they probably don't need it in the first place. Then about half and half in the 3s, and a dismal success rate in your GMFCS5. So they had a mean follow-up of 5 years, and just look at this graph, how it plummets, as the follow-up increases. And their predictors for failure was a migration percentage of more than 45, age more than 4.5, and GMFCS more than 2. So if you think about that and you go back to this, that should change to 45. If it's less than 45, and that should change to 4. And I think that is a sensible approach to planning which patients will actually benefit from soft tissue releases. So here we go. There's the incision, pectineus, there's your adductor brevis, there's gracilis, and there's adductor longus. You've cut that already, and then you see that. And there's the obturator nerve. So it is one of the options for treating adductor spasticity. It is not recommended anymore because it can lead to complete paralysis of your adductors, and they can develop a abduction contracture. And an abduction contracture is an extremely difficult situation to treat. The surgery for it doesn't work really well. The post-op management doesn't work, or is extremely difficult. So that's important to try and prevent that. So as I've mentioned already, I now routinely add proximal femoral guided growth whenever I do this sort of quadriplegic hip soft tissue package, which is the adductor psoas and hamstring lengthenings. And this is a relatively new concept. It's not brand new, but I would say less than 10 years old now is the concept of the proximal femur growth modulation for coxa valga, and specifically in cerebral palsy. So this is just a nice little summary of what the findings in this study from the JPO in 2019. And there was a steady decrease in the neck shaft angle and in the migration percentage. So the migration percentage wasn't terribly high to start off with. It was 33 plus minus 11, but it went down to a very acceptable 23 over the 5-year period. And if you consider that the natural history is progression, then regression is actually quite positive. So this is a minimal intervention, that can prevent major surgery in future or major pain and discomfort. The same study did have a few complications though. So 9 heads grew away from the screw. This happens. It's happened to me as well. Some needed to be exchanged for longer screws. There we go. And then 3 still dislocated and required osteotomies. But out of 56, 3 out of 56 is a very acceptable rate of conversion to osteotomy. So basically, they seem to think that if the migration percentage is more than 50, the guided growth won't work. Acetabular dysplasia will predispose to resubluxation, and you have to combine it with soft tissue surgery, which we do anyway. So this is just one of 2 of my cases. So you can't really see a dramatic change in the neck shaft angle in this patient, but notice how she's gone from subluxed to not subluxed. And this is in, I think, in a year and a half or so. And here's another one that shows you a much nicer sort of effect of what the screw does. So more than 50% subluxation, significant coxa valga on the left-hand side with the pre-op X-ray. And then 2 years later, you can see how that neck curls into varus. Now look, this is by no means a normal hip, but who cares? The patient doesn't walk. We just don't want the hip to dislocate. So this is very acceptable and actually quite a nice result for a very small operation. These were just, in explanation, these were some of my earlier cases. And I just always do both hips. You've got nothing to lose. But that looks quite nice. So that's guided growth and soft tissue releases. So then the next go-to operation for a migration percentage of more than 50 or so percent, would I say,
Hi, Prof.
so,
Sorry,
yes.
Prof. Can I ask a question?
No, no problem, Kizi.
What, why did you only do unilateral in these? I thought you do it differently now that you do both.
Yeah, that's what I said. So this was early on. This was early on in my career. I've learned a lot of lessons over time. And at that stage, I only operated for the pathological hips. So I used to do unilateral VDROs as well, and I'll get to that, but I now only do bilateral, and it's just a matter of symmetry. So even though, because you can see there is some valgus in this neck already, or as well, and here quite a lot. So it would have been beneficial to do both screws. I just didn't, but I've learned my lesson. But you're absolutely right. I do both sides now.
Okay, noted, boss.
Okay, cool. So same with the VDRO. So here's an example, and you can see this hip is normal, but I'll get to why we do bilateral now. But you see how nice and symmetrical it is now. So firstly, like I said, you get symmetry. You equalize the leg lengths. So even though they don't stand, it's still upsetting for the parents if the one leg is shorter than the other one. They don't like it. So then you just get a more symmetrical situation, and it has better long-term outcomes, which I'll chat about now. So here we go. This study looked specifically, and you can see this is a very new concept as well. So it's even newer than the guided growth. Is they compared the unilateral versus bilateral, and when bilateral, they mean bilateral for a normal hip. So it's not, if you have bilateral hip pathology, then obviously you would do bilateral hip osteotomies. And these results, no, there we go. I thought I had another summary. So basically, they were small. It was a relatively small study, only 18 at unilateral hip surgeries to 42 at both. So in the ipsilateral hip, they had 4 sort of recurrences compared to 1 for bilateral hip surgeries. The contralateral hip, 6 as opposed to 0, obviously, because you put the other one back in. The pelvic obliquity didn't increase as much in the bilateral hip surgery ones. And then the, what does that on the MPD, I can't remember what that stands for, but it's also better, whatever that was, I can't remember. And then the one in the unilateral group, the pelvic obliquity actually went the other way. And I've got some horrible x-rays I'll show you of what happens when you do that as well. We'll get to that now. And then when do we add an acetabular osteotomy? So the answer is easy, if there is acetabular dysplasia. So I wouldn't do it for very mild dysplasia, so a acetabular index of like 25 to 30, but I think anything more than that Adding a pelvic osteotomy doesn't add that much to the surgery if you're already there, and it does make a big difference. And this was a kid in whom I did, and we do this in one setting. It does take a while, but got these bilateral femoral osteotomies and then also bilateral pelvic osteotomies. That one's not my best work, but this one looks good. And look, this is a beautiful X-ray. I mean, you can see that with the varus, you actually increase the adduction of the hip. So you have to then in turn obviously do adductor releases as well. But with the shortening of the femur, you essentially lengthen the adductors as well. So it is okay. They still have good enough abduction after this procedure, but the varus does automatically decrease that abduction range as well. So then we get to the salvage surgeries now. So the castle procedure is nowadays my go-to if I have to do something. The alternative is the McHale osteotomy, which I'll show you as well. But the castle procedure is an extraperiosteal subtrochanteric proximal femoral resection. So you take out the whole femur from the left trochanter up. The importance of the extraperiosteal dissection is to decrease the rate of heterotopic ossification, because the osseous bleeding from the subperiosteal space just increases that risk. And then it's an interposition arthroplasty to a certain degree. So you take whatever muscle you can find, vastus, rectus, glutes, and the hip capsule, and you interpose it between the femoral stump and the acetabulum. So this study was looking at palliative surgery in cerebral palsy, and it's a review. It was a review article. It wasn't academic. And they did say that the palliative surgery reliably improves pain, seating, and nursing in the long run, but it has a very high complication rate. So proximal migration of the stumps, heterotopic ossification, decubitus ulcers, and postoperative pain. And this is the big problem. So even though they are fine eventually, for the first 6 to 9 months post-op, they are in a massive amount of pain. And I don't know how to make it better. I place them in traction usually for about 6 weeks to just let everything settle, but we give them NSAIDs for HO prevention, put them on gabapentin, clonidine, the works, but they're just still miserable until they get better. I just put here another picture of these horrible lips so that you never ever do this and let this happen. And this is just the post-operative X-ray of a castle that actually went quite well. So it looks horrible. This is the last thing you want to do in your life as an orthopedic surgery, is excise the hip. But it does have a fairly good functional outcome in the long run. And this is just a quote from Loveland Winter. And you'll say here, it's like, it's a very negative thing. So post-op complications include pneumonia, decubitus ulcers, infection, wound breakdown, and death. Pain relief is delayed and unpredictable. Adolescents may take a year to show improvement in pain, and there's high rates of HO. So it is just not something you want to do if you can help. The other salvage option, other than the castle procedure, which I now prefer, is the McHale. So the McHale is a combination of a proximal femoral resection, but at the base of the neck, so it's like a girdle stone basically, and then a valgus, and quite an extreme valgus osteotomy at the level of the lesser trochanter. And this is not dissimilar to a pelvic support osteotomy that you would do for other hip conditions where there's no femoral head. And the theory is that now the lesser trochanter is going to articulate with the acetabulum and function like a hip. That doesn't really happen either. But I think there can be some metaplasia that takes place there. And this was actually one of my best outcomes of this procedure. But you can see the problem. So most of these patients are extremely skinny and are malnourished. Now you've got this plate and the greater trochanter, if it hasn't remodeled like this one has, sticking there basically through the skin. And just this year, I don't know if Cindy's here, but we actually had to, yeah, so Cindy will remember, we had a patient that came in with a situation where we had to go and actually revise the femorectomies in theater because she was threatening the skin. I'm not really sure that the increased stability does facilitate weight bearing. Most of these children are so far gone that they won't weight bear anyway. But the big problem is the hardware and the impingement. And I have revised quite a few of my own and my predecessors' Michael's to castles, so I don't do that anymore. Here's just another example. Oh, I want to show you what happens here. So if you do the varus osteotomy at a very young age, they just grow back into valgus. And then you get this little 90-degree plate sitting there with the femoral head looking like this. So it's quite a resistant problem. Anyway, so then I did a McHale. This was also one of my earlier operations. I didn't do it very well. The osteotomy is too low. But then she impinged there. You can see it's almost like the femur fused to the pelvis. Then I did a proximal femoral castle. Then she formed HO, and again, she was stuck in this position. It was absurd because she formed this HO again, talking to the acetabulum, and then I had to cut out yet another piece of her femur. So this poor child ended up with about this much femur after everything she's been through. And then this is just lastly another one. So the one hip was okay. I elected to do bilateral McHale's for symmetry. I'm not sure I would do that again. But she was, in the end, she was actually all right as well. Hip replacement, I'll briefly speak about it. I've personally assisted one hip replacement in a CP. Before, it's not really something we do very often, and our arthroplasty colleagues aren't too keen to do it, but Tom Hilton doesn't mind. So he helps with that from time to time. It's a very specific indication that you would do this for, and not necessarily a GMFCS5 patient. But it does provide reliable pain relief. The 2 to 10 year survival appears to be reasonable. Obviously, you have to take certain precautions because they are at high risk of dislocation. So restraint liner, what's those things? Yes, those hip replacement stuff, it stops them from dislocating. You have to do those. And this is just some pictures from a book. These are not my patients. But again, yeah, you can see that horrible deformity there. And the alternative for this patient would have been proximal femorectomy. So I suppose if you have the facilities in the service and the will to do it, it is definitely a better option. Arthrodesis, not something I've done, but it is described. And this one study almost convinced me to start doing it. But hip fusions are such a story. It's not really a very easy operation to do. But they had 21 patients and hips that they did this for. A couple of problems, but I mean, they had 6 of the 9 bedridden patients could sit. One who used to be able to sit could walk. And then 1 out of 3 household workers became community workers. So this is like fantastic results. But like I said, I'm not really sure it's reproducible, and certainly not by me, but it's something to think about. Okay, so that's it for the hips, but the hips will come up in this part of the chat again. So the next most common thing, or the next, I suppose, biggest problem in the quads is scoliosis. And when I say biggest, because it's a big problem to solve. And it has quite a significant impact on their function, and not only on their orthopedic function, but needless to say, on their respiratory function, digestion, cardiac, and all of that. So again, more prevalent in the more severe CPs than in the less severe CPs, and you can see the numbers there. And the etiology is a combination of factors: spasticity, dystonia, weakness, muscle imbalance, the works. But I think it's probably mostly weakness, because if you look at all the other weakness conditions, so myelomeningocele, muscular dystrophy, the works, they all get scoliosis. And I suppose we must just remember that our spine doesn't keep itself upright. That is also dependent on muscles for staying straight. And if your muscles can't do that, then it doesn't stay straight. But they also get quite specific curves, so they don't get your typical AIS thoracic curves. They get these long C-shaped curves, and it's often left-sided. And then they get this situation. So you see these ribs. So if it gets really bad, they get what they call costopelvic impingement, where the ribs are impinging on the pelvis. This is how bad it gets. Poor kids. So it's typically rapidly progressive in the second decade of life, and it can continue until after skeletal maturity if it's more than a 40-degree curve, gets rigid quickly, interferes with seating, pulmonary compromise, and all of that. And you can see this is this guy's X-ray, and the curve involves his entire spine and most often the pelvis as well. So what can we do for that? So spinal bracing in quadriplegic CP, so it doesn't prevent curve progression, but in my experience, the patient like it. So especially when the curve is still relatively flexible, they don't have trunk control, and seating can help, and having nice chairs can help to keep them upright, but you often also have to strap them to the back like it's a whole story. So they tend to fall off their chairs. They look like this, it's like so. So if you just have a TLSO, keeping them upright in their chair, it actually makes them very happy. It makes the parents very happy because suddenly their child's not falling all over the show. They're sort of looking the world straight in the eye if they have head control. So I still prescribe it, even though I know that it's not necessarily going to prevent the curve from getting worse. At least while they're waiting for the curve to get worse, they're sitting up straight. So it's, I don't know, it's a nice thing. It's not scientific, but I like it. Spinal fusion is a wonderful operation. We know it works. It improves their quality of life. This has been shown with patient-reported outcome measures in long-term studies. It's a great operation. And I often tell my patients, of all the operations that I can do for a quad, the one operation that actually works the best is the one I can't do, which is the spinal surgery. It just seems to have the greatest impact on their general well-being when applied to the correct patient. So they almost always have to include the pelvis because, like I showed you, where's that? Yeah, so the curve, it basically ends at S1. So the pelvis needs to be included. And I think this leads to a necessity to be very pedantic about your instrumentation, that you get the pelvis level. Because if you fuse the pelvis oblique, then you're going to have endless problems with seating, unilateral ischial pressure sores, and so forth. So not that many of you are going to be doing this operation, but it's just something to bear in mind when you think about the biomechanics of the spine. So it corrects the pelvic obliquity because you include the spine, but it's a big, expensive surgery, especially how they do it in the States where they instrument every level. We don't, or Prof Dan doesn't. This is just a nice case. So this is one of my favorite patients. So she's not actually a CP. She had a head injury, PVA as a small child, but essentially then, post-head injury, cerebral palsy. And she developed this long curve, and she was just such a lovely kid. So they could stretch her out. You can see she's still quite flexible, and look how nice. Okay? So this made a huge difference to her life, better than anything that I could do for her. So what about the hip and scoliosis? Like, is there a relationship? And I have alluded to it already, that there doesn't seem to be a clear cause and effect relationship, like scoliosis causes hip dysplasia causes scoliosis. That hasn't been proven, and it's been looked at. But we know they both occur, and they occur in conjunction. So what hip dislocation does do is it causes pelvic obliquity, and what scoliosis does do is it causes pelvic obliquity. So whether or not those things lead to each other, it doesn't seem to. Does addressing the one prevent the other? It's not really sure. But here's a child where I think that might be disproving this fact. So one of my older CP patients, I tried the guided growth. I think he was too old. His hips weren't out, so I wasn't going to do anything massive for him. But he then went on to develop a very severe scoliosis, as you can see. And if you look at these x-rays, look at that hip. So now his right hip appears to be almost completely dislocated, but he's got this curve. Terrible thing. That's his traction view. And then he got a long, big spinal fusion, and look at that. Hip is back. So I do think that if there's a sublux hip in the presence of a severe scoliosis, it's probably not worth putting the hip back unless you address the scoliosis first. And that has kind of been my approach for the last several years, is if the patient isn't a candidate for spinal surgery, it's not going to get his hip operation in that clinical context. So then there's just some other evidence, like trying to look at the same thing. And the recommendation from this current concepts review was that you must address the most symptomatic problem first. So if you have a mobile pain-free hip that is subluxed, do the scoliosis. If the hip is painful and stiff, salvage or recon. And then it also depends on the type of the scoliosis. Is it flexible? Is it rigid? And the pelvic obliquity. So these are just guidelines. If you're looking at a patient, you're thinking, oh, should I do the hip while he waits for his spine? It help you decide. So this is another example of where things also went horribly wrong. And this patient also refers back to when I still used to do unilateral hip video ROs, and before I learned my lesson about doing something for the hip when the spine's not being addressed. So this case illustrates both those errors. Plus this patient was too old probably. So at 10, this is what he looked like. That was before I started. Then I met him at this age. And he had this hip, 13 years old, with this scoliosis. So the hip is out. I must put it back, which I did. I even did shame. This, like I said, this was basically when I just started as a consultant. This isn't really an excellent data. I don't think it changed the stability index at all, come to think of it now. But the VDRO is nice. And the hip is in, and I was very chuffed. And then stayed in for a year, and then a year later started coming out again. Now you can imagine what this kid looked like clinically. He was this I don't know, it was like S-shaped, because you'll see why now. And this was at 16, and that was his scoliosis. And the lesson learned here, and I think that's very clearly illustrated, is leave the hip, it's pointless, fix the spine. Because he was actually a good candidate for surgery. It's like a well cared for, like nice little kid. But by the time he looked like this, his parents just weren't interested anymore. So that's So that's the hips and the spine, and that's basically the main event in the non-ambulant CPs. But we'll briefly look at these things. So the knees, you want them to be able to flex to 90 degrees so that they can sit. Remember, that's our goal in non-ambulant CP, is comfortable seating. If the popliteal angle is more than 90 degrees, so remember, popliteal angle is with the hips flexed to 90. So if you are sitting, your hip is flexed to 90. So if your popliteal angle is more than 90, that means that your knees are, your feet are basically under your bum when you sit, and that's not good for wheelchair seating. So that would be an indication for doing something for the knees. And then you can do hamstring lengthenings, distal femoral extension osteotomies, which I would not really do in a quad because it's too big an operation. But maybe in the GMFCS4s, who has some ability to stand and cognitive function. And then in the cases with very severe extension contractures, you can also do things like a quadriceps palsy or a femoral shortening to get the knees to flex again so that they can sit. And the feet, they mostly get equine varus feet, but they can get anything. The plantar valgus feet, you don't need to do anything about because they just need to be able to wear a shoe. But if they've got a bad equine varus foot like this, then surgery is, in my book, indicated. And we do a variety of fusions and osteotomies and so on. It's not necessarily different to what I would do for deformities in other conditions. I'm just more likely to do an arthrodesis for them because we're not concerned about adjacent joint degeneration in them. The upper limb in CP. Okay, I'll take a pause. I'm just going to have something to wet my throat. Okay. So the typical deformities in the upper limb, we know these. So shoulder adduction, internal rotation, elbow flexion, pronation. Sorry, you can't see my hand. Wrist flexion, finger flexion, thumb and palm deformity. This is the CP hand. Okay, and there's a clear illustration of the CP hand. So when we evaluate the upper limb, it is very important to watch the patient move. So you cannot just go and correct every deformity you see in the upper limb, which is kind of what you can do in the lower limb, because in the lower limb, you're very dependent on like mass actions. You can walk on a peg, basically. You just, but the hand is obviously a lot more intricate, smaller movements, more specific functions, and any injudicious deformity correction can easily lead to a decrease in function in these kids. So watch the patient performing tasks, watch how they handle the objects, look out for heavy neglect. So you would often get them to try to get them to do something and they just ignore the affected limb. They don't even try. So there you can see the little guys desperately trying to open his hands, but he just doesn't have that selective motor control to actually extend those middle two fingers and the thumb. So the thumb is a problem. You can't grip objects if your thumb does this. And what you often see with the patients, with the spastic patients, is when they're not focusing on the limb is quite relaxed, it's like in sleep. But the moment there's volition to try and do something, it's like this spasticity and a certain degree almost of dystonia just stops them from being able to do it. It's a very strange manifestation of their spasticity, but it's an important thing to look at, because if there is even a little bit of function, so if the patient is able to gently grip something, even just to hold it so his other hand can do something with it, and you do an operation, like let's say you do a tendon transfer that puts the hand like this, but now the fingers are like this. Now you have to lengthen them. Now they're weak. Now you've got to use this hand. You see, so every little bit of hand function is valuable and should be preserved. So you must be very careful. And I do a lot less upper limb surgery now than I did 8 years ago. And it's because I've realized that it's not predictable. You seldom really make them better. Sometimes you make them worse. So I'm extremely minimally invasive now, or what's the word, conservative when it comes to the upper limb. Done that. Okay. We also look at the resting. So I mentioned that. So the resting posture, what happens when they're distracted. You see there, she's desperately trying again to let it go, and she can't, her fingers just won't open voluntarily. And you can't operate that better. That's a brain problem. And then obviously you also look at the active and passive range of motion, spasticity, sensation. But function is by far the most important indication for surgery, or contraindication for surgery, as it were. This is a nice classification of the upper limb in CP. I know there's hundreds of them. I don't even have them in my talk. You know, there's Ankoli and the house thumb and all of those. So you can know about them if you want to. I don't really use them much, but this is for me important, because this is to me almost like the GMFCS of the upper limb, because this will tell me whether my surgery actually improved the patient. And this is so it's a functional classification. It's quite a long one. I don't know it by heart, but it groups it into the broad categories of passive assist, which is essentially I can put my hand down and hold a piece of paper there, but my hand itself cannot do anything. Then there's active assist, where my hand is doing something on its own, and then spontaneous use. So that's like just a nice way of thinking broadly of what the function of the upper limb is. So you might think, oh my God, this is so irrelevant to my life, but some of you actually want to become hand surgeons, and you're going to see post-stroke patients, and they're going to be exactly the same. So the house classification probably won't, I don't know if adult neurologists use this, but it's the same concept. And I think that the same principles apply to your post-stroke patients than to cerebral palsy to a large extent. So the indications for surgery, function versus cosmesis, we spoke about that. It's not predictable. And actually, I've already said all of that already. So you go from this hand to this hand, make it long, use this hand. So what about Botox yet again? And it keeps coming up, but that's because, well, first, when Botox came out, everybody was like super excited, because now it was a accessible solution to spasticity, and it works. Botox does work, as we all know. But it is not a panacea. It's not the solution to everything. And I was speaking to a colleague of mine from Joburg recently, and he was telling me how the neurologists there go like mad with the Botox. So they would do like 8 patients a week. They inject the quads. They do Botox over and over and over with zero effect. Why? Because it pays well. So non-surgical people do not make a lot of money. So imagine you had to, oh, you guys don't know yet, but if we had to make money just from consulting, we would have to work very, very hard, and nobody would have their kids and bishops. So these guys, if they could make like a few thousand rand by doing an injection, that's obviously very beneficial for them. So they completely over-service the patients. Anyway, I digress. But Botox, again, has a limited role in spastic limbs. mostly as a therapeutic trial. You're not going to repeatedly Botox. And I mean, you can't just Botox the arm for the rest of the patient's life. It's ridiculous. So there was a good study, actually. This is a very nice one. It was a prospective randomized control trial, or I don't think it was randomized. It was just a control trial looking at Botox in a specific protocol and tendon transfers in a specific protocol, and comparing the outcomes. And no surprise, the tendon transfers had a long-lasting good effect, whereas the Botox had almost no effect in the long-term follow-up. So they would be intermittently better or briefly better, and then just return to the baseline function. And the patients who had the Botox in the Botox arm, their fixed contractures actually worsened. So, no. Botox for dystonia is something that I do, and that I do actually, that I quite like. I wouldn't say I'm a fan of it, but I do like it. Again, very specific indications. And the reason why I would rather do Botox in dystonia is because surgery doesn't work for them. There's no neurosurgical solution. So for the spastic arms, you could think about doing a selective peripheral neurotomy or something. Well, not you, but the neurosurgeons. But for the dystonia, there's no operation. So if the Botox can work, and I want to show you this video. So this little girl, she's one of my patients from Agape in Mitchell's Plain, Esther. And when I considered doing Botox for her, so just listen to her while I talk, is I try and see what their repetitive pattern is. So by the fact that she's holding her Easter egg in her right hand, makes you think that her right hand's probably her best hand. But she's constantly here. So she cannot perform midline tasks because her repetitive or her habitual pattern of movement is this abduction, external rotation, elbow flexion. That's where she goes. So after a long discussion with her physios and thinking, I said, okay, well, let's give it a go. And I'll be lying if I tell you exactly what I injected in her, but I think I did deltoid, the external rotators, and then the biceps to just try and get a little bit better. And this is probably one of the best Botox results I've had in my life. So this was Esther's effort of drawing a little man before the Botox, and this was after the Botox. And I don't know, I must say this, yeah, this was for me was very telling. I mean, she clearly could just not get a hand to do what she wanted to do before that intervention. Unfortunately, even though I did the exact same thing twice more in her, there was like a diminishing effect. And after the third attempt, there was very little improvement and we stopped. But it's still something I would do. The other indication is cervical dystonia. So you get some of the dystonic patients that are constantly doing this and they can't focus in class, can't look at you when you eat. And by doing their sternocleidomastoid, actually has a very good effect. So that's Esther. Okay. So what operations are available for the upper limb? We'll briefly go through this. So for the shoulder, you're addressing the existing deformities, which is internal rotation and adduction. So you can do lengthening of pec major and subscap. Latissimus dorsi and teres major transfer. So that's the same as you would do for your brachial plexus palsies. And then even the humeral derotation osteotomy. I've only done the tendon surgery. I've never done an osteotomy for this. For the elbow, Z lengthening of the biceps, brachialis, anterior capsule, and then also the flexor pronator slide. So basically everything that crosses the elbow. And I used to think this really works very well, but in the last few years, the patients just recur. I really haven't been very impressed. And I don't understand how it happens, because if you cut like the whole brachialis, the whole biceps, the whole brachioradialis, how do they still flex their elbow? But they do. So I've been a little bit disappointed with the result of this surgery, whereas it used to be, I used to think it was one of the better ones. For the pronation deformity, if it's relatively dynamic, pronator teres rerouting works quite well. So you take the pronator teres from the polar aspect of the radius, reroute it through the interosseous membrane, put it on the dorsal aspect, it becomes a supinator. So that actually is quite a nifty operation and it does work. You could also just do a tenotomy or a tendon lengthening. And then in extreme cases, again, this is described, I've never done it, so radial derotation osteotomy. The wrist flexure and ulnar deviation, the traditional surgery for that would be a FCU to ECRB or a FCU to EDC transfer. And the theory is that that also improves supination in the hand. So it's like a win because you lose your flexion and ulnar deviation, or you decrease it, you increase wrist extension and finger extension, and you increase supination. The problems I've seen in this one is they end up with a wrist like this, which is also not so great. So nowadays I try and be a little bit more sort of, I would do a FCU lengthening maybe rather than doing a transfer, or, try and do something else that isn't as extreme, because if you transfer a spastic muscle, you can easily develop an opposite deformity. And if you think about the feet we spoke about a while ago, we do split tendon transfers for the feet, not full transfers. And it's for that same reason. So it's something to think about. Thumb and palm is a very tricky one, but the traditional procedures would be a release of your adductor or flexor, adductor pollicis, of the third metacarpal and the first dorsal interosseous, and that's a Matev release. And then in conjunction, you should probably do something to augment your thumb abduction. So the one option is something that, again, I haven't had wonderful success with, which is an EPL rerouting. So you take extensor pollicis longus, reroute it past blisters, round again through the metacarpophalangeal joint so that every time EPL pulls, you get abduction of the palm. Doesn't really work. So now my new thing is I take palmaris longus and I put that on the first dorsal compartment. That seems to be working a little bit better. And then another addition to the surgery is I now K-wire the joint for 6 weeks while everything heals. Because if you just put it in the slab, the slab doesn't work. And you can do arthrodesis as well. Lots of options. But the workhorses, the ones that's the most frequently reported on and perform is FCU to ECRB, pronated teres, Matev, EPL, and so on. And this is a little girl. She actually had quite a nice result. It's one of my earlier surgeries. So she had a Matev release and a FCU transfer. And I thought that was quite nice. But she recurred, and actually just recently I did something else for her. What about cosmetic surgery? So if you have a completely useless limb, so you look like this, it's embarrassing for the teenagers. They obviously don't like it. It becomes a big sort of cosmetic concern. So for them, we're not trying to do functional surgery yet, or it's a cosmetic operation. And what I do for them is I do a very radical elbow release, wrist fusion. And then there's a non-functional tendon transfer with FDS to FTP to basically cause a one tendon finger and FBL or whatever else you need to lengthen, and you try and mimic the normal cascade of the hand, and you don't expect them to work at all. And it looks like this post-op. I'll show you now. Look at that. Yes, I was so chuffed. So we went from there to there, and I thought, yo, look at that beautiful hand. But because the tendons are still not working, it never stays like that. It's like they lose like their interphalangeal flexion. They get these funny little stiff fingers that still look a little bit claw-like, but they still like it. They like it more because the arm is straight, it hangs by their side, and they sometimes, most of the time, they actually tend to pull their sleeves over their hand to hide it a bit. But at least it's not this in-your-face thing that causes them so much embarrassment. So even though it doesn't really, like, it never ends up looking like that forever, but it's still better than nothing. And that's it. That's everything. Okay, cool. So that was nice and quick. Any questions from you guys? See who's here. Okay, well, it doesn't look like it. So thanks everyone for joining. And for a good academic year, I think. So let's all enjoy the reprieve. Even this Friday's workshop was cancelled. So now we can all start getting into the holiday spirit. Okay, good night, everyone. See you.
Thanks.